here to listen to the lectures of Dhruvi ma'am and Bansi sir. I'd like to introduce the chairpersons for this session, Dr. Malay from Rajkot and Dr. Meet from Ahmedabad. Over to you, Malay sir.
Okay. Thank you, Dr. Tarjani. Hello, Rakesh boss. Hello.
Hello.
Hi.
I think we are not live.
Here
So, are we live?
Listen to the lectures of Dhruvi.
So we are live.
Okay. First of all, special thanks to my mentor, Dr. Bansi Sabu sir, for giving me this opportunity. And thank you, Sanofi, and welcome all delegates. So today's iSchool 2022, 100-year of theme insulins. And our next topic is barrier to insulin therapy with none other than Dr. Bansi Sabu sir. There is no any introduction required for sir. Over to you, sir.
Thanks, Malay. So thank you, Meet and Dr. Malay, for accepting as a faculty member for this iSchool. So let me start with my slide presentation. Sorry. I'm sharing the screen. All done. You can see slide?
Yes, sir. Yes, sir.
Good. So what I am going to talk in next 25 minutes, the barriers in insulin therapy. To introduce the barriers in insulin therapy, we know that glycemic control in Indian type 2 diabetic patients, largely they are suboptimal. This is one of the paper which was published in American Diabetic Association meeting by Dr. Shashank Joshi and many more investigators from our country. Is a landmark trial, which is talking that out of 5 Indian type 2 diabetic patients, actually one is achieving glycemic control of less than 7. It means 80% of the diabetic patients are actually not getting good control of diabetes. But if you see in last 20 years, there are so many such papers were published from 2004, 7, then again in 12, 15 and 19, and now this 2021. All of them are talking that 2/3 of our diabetic patients are actually not having a tight glycemic control, even though we have so many medication which had come in last 15 or 20 years. This suboptimal glycemic control is responsible for increasing risk of type 2 diabetes patients' complication. And this we know that uncontrolled diabetes or somebody who is not getting diabetes regularly treatment leads to more complications. And this is a slide which is talking that higher the A1C, more the complication, whether you talk of microvascular complication or mix of diabetic food or MI or other macrovascular complication also. Now, what is the meaning of OAD failure? When you will say that patient is now no more can be controlled on oral anti-diabetic agent. When A1C remain above goal, this is one paper which is Sushil Jindal had published before some time in 2020 only, that despite 3 oral anti-diabetic agents of different class, maybe metformin, second preferably sulfonylurea, and third could be as per the comorbid condition, if we add all 3 and still sugar is not controlled, or somebody who is having symptoms of insulin deficiency, it means uncontrolled diabetes, sugar is more than 300, or they have symptom of like osmotic symptoms or weight loss, these are the patients also should be started on insulin, which is what we call it oral anti-diabetic failure. We were, in our long back in our pathology book, we were reading that there is a primary oral anti-diabetic failure. Now we consider that these are the patients primarily actually insulin deficient, and we started them on a oral anti-diabetic agents. These are the patients who are not getting control even after 2 or 3 drugs, but within first 6 months or maybe after 6 or 8 months, 9 months, these patients not getting good control because of oral anti-diabetic agents. We call them primary oral anti-diabetic failure. There is a Also one term is a secondary OAD failure. There is nothing like a secondary OAD failure over a period of time, a uncontrolled diabetes and multiple oral anti-diabetic agents which we had used. It is actually beta cell failure, and now there is no adequate response to these oral anti-diabetic agents, and it does not give a good control of diabetes. So this is what we call as oral anti-diabetic agents are getting failed over a period of time. But when patients are not getting control even after 3, or in some of the condition even with the quadruple therapy, and patient sugar remains uncontrolled, that's the time when they should be started with insulin. Now normally in India, out of 3 or 4 patients of type 2 diabetic patients who are started on insulin, but they are started after 10 years of diagnosis. Some of the patients, even when they are to be started, further 5 or 10 years is further delayed in the patients to start with the insulin also. This delay in insulin initiation leads to micro and macrovascular complication, as I already told you, but this is also one paper which is, we are talking of UKPDs, where the median time to incidence to type 2 diabetes patients complication is roughly between time of diagnosis to it is within 6 years. Most of the patients will have some or other complication if they remain uncontrolled, and the patients who are not started or initiated a timely or escalated the therapy as per the requirement, then they will develop a lot of micro and macrovascular complication. So there are multiple barriers in insulin therapy. We can broadly divide them on a patient-related and physician-related barriers. The patient-related barriers are the patient feels that he can't take the insulin. There is an insulin distress, and that's extreme apprehension is there with the patients. He feels denial, that he does not want to accept the fact that his sugar is uncontrolled, and he does not want to accept that now he has to be on insulin. And there's a lot of discomfort in the mind that emotionally he is disturbed to take the insulin therapy also. So there are insulin distress, which could be acute or short term. Some patients have a chronic distress. They don't want to take, even the doctors had told them multiple times since last so many times. And there are patients who take the insulin, but then after some time they again reject. They don't want to take it continuously. And that sort of distress also we see in our clinical practice. There are factors like misconception regarding insulin. There is an injection phobia. There is a fear of weight gain and hypoglycemia, negative impact on social life and job, and poor health literacy. I will say that it is the negative impact on social life and job, poor health literacy, misconception about insulin risk. There are others. These factors are very, very important in compared to insulin injection phobia or fear of weight gain or hypoglycemia, because they may not understand that hypoglycemia and weight gain is a major challenge for these longer acting insulin, which we are going to start with them. So the patient-related factors which are contributing to this distress is misconception, beliefs which they have in their mind that, once they will be started on insulin, it cannot be stopped. There are some logistical barriers also. They may not get insulin in locally. They have already a lot of concerns who will uptitrate the dose, how they will do. A lot of anxiety also while starting the patients on insulin therapy. This is a paper which is in a DiabCare study in 2011 that majority of insulin naive patients mainly agreed on one question, that I am worried about having to start an insulin. That's almost 25% of the patient. And 25% of the patient, 23.5 odd number is they are saying that starting on insulin would mean I have not followed my treatment. So they will have a guilt of their sugar remain uncontrolled, and that's the reason they are on insulin. Over 5% of physicians felt that greatest barrier to insulin therapy from patient perspective were they have fear of injectable therapy and at the same time pain of injection. The cost of injection and lack of awareness is also one of the important factors which they feel that's the reason patients are not ready to start insulin, particularly type 2 diabetic patients when they are to be started. So 3 important steps for abolishing patient barriers. What are those? Patient education. The next one is again patient education, and third is again patient education. So these 3 important steps mean all steps are only patient education, education that can only abolish the patient barriers. Now, what are the ways or what are the practical tips for educating the patient? Identify their personal obstacles and address them. That's most important thing, where they are feeling that why they don't want to take the injection. Could you tell me some of the reasons which they feel that strongly about not taking insulin? Restore a sense of a personal control. We have to introduce insulin is a brief temporary experiment. Let's try for a month and see how you feel. That sort of thing we can do. Frame the message very appropriately. Talk about the benefits to their health and talk about the targets. Let us consider that this should be your A1C. Your health will improve by giving it, and we should target more about their health, and for positive health we should talk. Explain the progressive nature of diabetes. It is not the patient failure. It is sometimes the disease, it's progressing so fast. It is beta cell failure. Over a period of time, the patient may develop beta cell failure, and he was already on multiple oral anti-diabetic agents. Now it's a time that the patient has to be on insulin. So we have to explain the patient that also. Tackle the injection phobia with the newer injection, newer pen with the small size of the needle, small size of the pen needle. It does not cause any pain. Talk about the hypoglycemia. The risk of hypoglycemia with basal insulin is again very less, so that we can talk about it. Considering the use of insulin pen, and don't use insulin as a threat. And that's very important, because many times the primary care physician, they just talk the patient that if you will not able to control your sugar, we will start you on insulin. And this is like a threat. Patient always feel that if I could not control the sugar, it means I will have to be on insulin. So that should not happen when you are dealing with a type 2 diabetic patients, and don't use insulin as a threat. These are some of the practical examples for patient education, that I don't think I need insulin. I'm not really that sick. Can't I put it off until the diabetes get worse? So, this is the most common thing which we see. Our patient always have this type of statement. They will say that, no, I don't think I need insulin. And insulin not the treatment of last resort. This is most important thing which we must tell it. It is not like that if I have started you on insulin, it means there's something like you had become very sick. We don't start the insulin when somebody is very sick. Rather, we want to start somebody to not to become sick, and we want to prevent the complication. And that's the reason we want to start you insulin at this point of time, to prevent further complication. Starting insulin does not mean that your diabetes is worse. The insulin can help you stay healthier. And this should be the answer when somebody says that I'm not really that sick. Why you want to put me on insulin? The second sort of statement the patient may make it, that does needing to go on insulin mean that I have failed to manage my diabetes? Needing insulin does not mean that you have failed. Over time, your pancreas make less insulin and your body needs more. So that insulin you take is just replacing insulin that your body is no longer making. So it's not like that he is failed. It is the beta cell which is failed. It is the pancreas which is now not making sufficient amount of insulin. And that's the reason the patient should be on insulin. After my grandmother went on insulin, she suffered from all sorts of complications like amputation. I'm afraid of same thing happening to me. Now, this is very commonly asked question by the patient. They feel that when insulin was started, then they have developed the amputation, then they have developed the kidney failure. But actually it is not that, because at that point of time, the mother or grandmother or uncle who had developed some complication, for that doctor had started the insulin. So it's like that after the developing complication, or the patient might be having some diabetic foot problem and the patient was started on insulin, and later on amputation had happened, but the patient relative may feel that it is after the insulin initiation, actually the amputation or a kidney failure was there. So we have to explain that these problems were not caused by insulin. It is the diabetes complication. They were caused by the diabetes. And by starting the insulin at appropriate time, we can prevent the complication. Somebody had started the insulin to your grandmother when she was already having diabetic foot. Rather, we are starting the insulin to control the sugar. And once we will control the sugar, probably these complications can be prevented. Doesn't insulin cause the pancreas to stop working? This is also, if I will take insulin from outside, it means my pancreas, whatever amount of insulin which pancreas is making, it will not be making. It will stop, but that's not true. Insulin does not damage or slow down the pancreas. Rather, by giving insulin, you are giving rest to the pancreas. And glucotoxicity itself will also improve the beta cell function. So by resting and by improving the beta cell, the glucose control, improving the beta cell function, rather it will improve the pancreatic function. And in some case, even after some time, we have seen that patient who is started with multiple daily insulin injection, probably after some time they may get control only with a single shot of injection too. It does not insulin cause low blood sugar. Yes, hypo is a major concern. And we were having more hypo concern with premixed insulin. Now with the longer acting insulin, which is basal insulin, which is primarily controlling more of a fasting sugar and which you can also titrate, the chances of hypoglycemia are less. And with better and better quality of insulin, the chances of hypoglycemia will be further less. The dose can be adjusted, patient can do on their own also, and self-monitoring helps, and it can reduce the risk of hypoglycemia. If I choose to be on insulin, how much will it affect my daily life? Again, as I told you, if we start the patients on a long-acting basal insulin analog, that has to be taken once in a day. It has to be taken at bedtime. And the possibility of that somebody is saying that how it is going to affect my daily life, I don't think by giving you one shot at a bedtime may not affect that much daily life. If somebody is on a multiple daily insulin injection, that too before lunch and before dinner and before breakfast, yes, there will be some change in their lifestyle. While that starting a patient or initiating a patient on a single dose, probably it will not have that much effect on the daily life. Is it oral pill medication? Is an easier way of treating my diabetes, and this is very common that you increase to more dose, to more pills. But sometimes when already you had used 4 or 5 different varieties of oral anti-diabetic agents, now there is the thing which can help the persons of diabetes to control their sugar. So it is the pills are not with the insulin. They feel sometimes that you give me oral pill which will increase my insulin secretion. Taking insulin is too much complicated. That's again not true, because taking insulin from the pain, that too on a single shot, will not be very complicated. And by monitoring once in a day on a fasting sugar and alternate day on every third day, we can titrate the dose also. Once I start on insulin, will I be lifelong to stop? I will never be able to stop. That's maybe true for some of the patients. For some of the patients, even it can be stopped also, because sometimes we start the insulin only for temporarily to control the hyperglycemia, severe hyperglycemia, some of the condition like steroid-induced hyperglycemia. And sometimes by giving the patient insulin, as I told you, it gives rest to the pancreas. There will be more improvement of beta cell function, and maybe after some time, you may stop insulin also. If I give myself a shot, won't it be painful? And that's what I do in my clinic practice, that I ask the patient to buy the insulin in front of me, and we give first shot in front of us only. So, I mean, that apprehension, that anxiety by taking himself, that it will be very painful, that goes away immediately. I hear that insulin causes weight gain. Yes, it can, but it will increase the weight only 2 to 3 kg and not much. And that also we can manage with good lifestyle modification, because once you start getting control of the sugar, yes, there will be some increase in weight, and that with the basal insulin, that weight gain is not very high. So initiating the insulin with basal insulin probably will not increase that much weight, while initiating the patients on a basal and with bolus or a multiple daily insulin injection, there will be more weight gain, but that we have to explain, and that also we have to manage with lifestyle modification. And now with the medication, which is like GLP-1 and with SGLT2, I think we can mitigate this weight gain also. So the practical steps which considered to mitigate insulin distress. In summary, this is already Jimit had talked the same slide, that we have to explain the benefits of insulin for effective glucose control. We have to build the trust with the patient. That is most important thing. Demonstrate the process of insulin injection in front of us by doctor, by diabetic educator, by dietitian. Provide moral support to the patient. And the last, very important, that discuss patient fear and anxiety, which are related to the insulin initiation. So these are some of the practical steps which we have to consider while starting or initiating the patient on insulin therapy. The insulin specific conversation. Maybe a patient who is before patient needs an insulin, we should talk about the diabetes and the role of insulin. At the time of initiation, we should talk of again the benefits, but insulin technique, which is very important. So when patient is already agreed to take the insulin, at that point of time, we should talk about the injection technique. About special topics, when he talks about the hypoglycemia, or when you have already started the patient on insulin, you please explain the patient about the hypoglycemia and weight gain. As patient come back for the follow-up, maybe first follow-up, there are some concerns related to the injections. There may be injection technique. We must see again whether they are doing it properly, titration whether they are doing or not, or what about the self-care which they are doing. When they are coming for long-term follow-up, that injection technique again to be seen. We must see in front of us where they are taking the injection. See for hypodystrophy, insulin dose, whether they are rightly taking or not. See their self-monitoring of blood glucose diary, whether their glucose is getting control or not. Whatever we have educated, whether they are uptitrating the dose accordingly, or dealing with the special situation, like somebody have already developed in between some other problems, or a person with elderly or a renal disease persons, then we have to consider these patients the dose adjustment accordingly or according to their requirement too. But there are a lot of physicians related barriers also. We had talked about the patients related barriers, but there are a lot of physicians related barriers. Physicians related barriers are, again, I will talk that it's clinical inertia. What others? It is clinical inertia. And what else? It's clinical inertia. So the physician related barrier, I will say only one thing, that it's a clinical inertia. And what is clinical inertia? Clinical inertia is defined as a lack of treatment intensification in a patient, not an evidence-based goal for care. It means failure of healthcare providers to initiate or intensify therapy when it is indicated. And this is what is happening when we are talking of insulin initiation. Healthcare providers are not initiating at right point of time, at appropriately, and they are not intensifying therapy, even patient A1C remain uncontrolled. Why physicians, they don't follow the clinical practice guideline? We don't know, but this is the fact, and this is one of the trial, and which is one of the paper which is published, that many of the physicians, they don't follow the clinical practice guideline also. What is the conventional approach? The conventionally, they try to approach the patient with a uncontrolled diabetes, would like to escalate the therapy, but the patient's A1C remains around 8. Not like intensifying the therapy and keeping HbA1c around 7. That's what we should do. So when somebody's sugar is not getting control, as soon as sugar goes above 7, 7.5 or 8, this should be intensified for therapy. I'm not talking only of insulin, intensifying the therapy, intensifying the lifestyle modification, and they should try to achieve the A1C of target of less than 7 or 7.5 accordingly. But they should not be capped A1C of around 8 or 8.5, which is most of our Indian diabetic patients are there. Almost, I have told you, already 80% of the diabetic patients who are uncontrolled. This is what even some of the patients who could achieve the A1C, and this happens also very often, that a patient may show you that last report was absolutely well controlled. Even before 6 months or 1 year, my sugar was well controlled, but now I am not having. And this is very common, that patients who are on multiple oral anti-diabetic agents, they may show that. Here in India, sometimes they just try to show a random blood glucose level, that last time my glucose level was absolutely well controlled. It was 150 or 170, and I will again able to achieve the same sugar level, or I will again able to achieve the similar A1C level. Maybe before 1 month or 2 months, my sugar was well controlled. But now the A1C is very, very high. So the physician barrier are failure to initiate treatment, failure to titrate or treatment goals, failure to set clear goals, underestimate patient need, failure to identify comorbid conditions such as depression. So these are the physician's barrier, which are very often, which we see for not achieving the tighter glycemic control. These physician-related factors also, like they are concerned for hypoglycemia. They also feel that there's a lot of difficulty for flexibility. Sometimes they feel they judge the patient, that patient will not able to take it, and they may feel there is a limited access to the medication also. Now, what are the steps for that? And the steps for them is education. Education of the doctors, self-updation on recent advances. There are conferences like these type of scientific platforms, industry-driven conferences may be also there, but peer-to-peer discussion and peer-to-senior discussion will definitely help, and it will build the confidence for self-practicing also. The channels for these, the face-to-face interview, telephonic-based supports, web-based programs, and mobile-based health apps, they all can help for insulin initiation and intensification for therapy. The motivational interviewing, which improve the insulin acceptance in people with type 2 diabetes patient, which is also which can be done as a motivational interview, which can help the patients to accept the insulin. And these are the ways by which we can improve the care for diabetic patients, and which can also improve the acceptance for initiating the insulin therapy, and at the same time intensifying insulin therapy. With this, I thank once again, thanks to Vipul and all the organizers for iSchool, particularly Sanofi, for giving me this opportunity. Thank you.
Thank you, sir. As usual, wonderful and very elaborative talk for various barrier to the insulin. So right now there is no any fresh question in the chat box. So shall we move to next? Okay. So our next speaker is Dr. Dhruvi Aznani, my dear friend. She is a MD and fellow of Royal College of Physicians from UK. She is also a fellow of American College of Physicians. She is PG Diploma Diabetes from RSSDI. She is an ISPET Fellow of Pediatric Diabetes. She is a consultant diabetologist from Rudraksh Institute of Medical Science. She is a HOD Clinical Research at RIMS Ahmedabad. She is a Treasurer RSSDI Gujarat Chapter. She is also a winner of Torrent Young School Award for the Diabetes TISA. She is a faculty for National Diabetes Educator Program and speaker at numerous international and national conferences, and says 10 international and 25 national publications, and reviewer for Pediatric Diabetology Journal and Journal of Diabetology, and she is an investigator for clinical trials. So with that, over to you, ma'am.
Thank you so much, Malay. First of all, it's a really nostalgic feeling for me being back in Diet Air and giving my presentation today. I hope it has been a wonderful first session, and our second one with Banshi sir telling us all about barriers to insulin therapy. I'm trying to share, but share nahi karta. Ek second. So we are today going to be talking about insulin pump therapy. When we talk about insulin and insulin pump, the first thing that comes to our mind is, something that is so cumbersome to operate, something that has a lot of spare parts that we have to work along with. And the second idea that comes to our mind is that it's generally for type 1 diabetics, but it's not so. I don't know. All right, share kariye. Open system preferences. All right. Some technical difficulties, especially when we are talking about some newer technology, is bound to, put us on our toes again. Portion of the screen. All right. Guys, you'll have to give me a second. So mail karega na matij tarjini na matij. All right, guys, we'll be back. Malay, if you can take a couple of questions, give me 2 minutes and I'll be back.
Okay, ma'am, no problem.
Maybe meanwhile, if we have some time, we can take the advantage of having Dr. Banshi Sabu answer a few of our questions. He has delivered a very excellent talk on a very important topic. First of all, compliments to iSchool and the whole team for organizing this symposium specifically on insulin only. And I'm sure with programs like this, we will be able to address some of the barriers of physicians. I can see that there are a lot of physicians who are watching this event live, and definitely with Dr. Sabu's talk, we must have been able to convince at least a few of them to initiate insulin in timely fashion. Banshi sir, you addressed a lot of questions related to barriers, with insulin initiation. One of the commonest barrier that I face is that most of the patients, or I would say every patient says, Dr. Sahab, iski आदत पड़ जाएगी. एक बार लग गया तो छूटेगा नहीं.
मैं इसका एक बहुत सही आंसर देना चाहता हूं. मेरे को लगता है कि when we are starting the insulin, we are not very confident. It's the doctor confidence which makes difference. I give an example and I always tell my colleague, my physician friend, or even my students that when you are writing a insulin, you should be very confident that this is the right time to start insulin. I just give an example. Suppose you have a patient who is type 1 in front of you, to whom you have to start the patient on insulin. Patient parent, the child himself, the grandparents, everybody is crying. And they are saying, Doctor Sahab, insulin mat dijiye. So they are saying that, we don't want to take the insulin, sir. it's very, very, costly, or it is painful, how the child is going to take. But the doctor is very confident, if I will not start this child insulin, child will die. And you will say, nahi, aapko insulin lena hi padega. There is no option, And aapka wo confidence dekh ke patient get start insulin also. The similar way, you are seeing a patient with a myocardial infarction, suddenly the ECG is showing like this, it's a painless, hardly there was any pain, but there is a hyperacute MI. Patient is saying, मेरे को तो साहब थोड़ा सा acidity हो रहा है, and you are saying, no, आपको heart attack आया है, आप hospital में दाखिल हो जाओ. वो कह रहा है साहब घर पर शादी है, I have some function, but nothing I can do. No, you have to get admitted because this is what is a myocardial infarction. So the patient sees confidence on your face, how confidently you are saying, and I am sure that same patient will get admitted also. Sometimes we have to explain the patient that I am writing my best treatment as per your condition. If you don't want to accept, if you don't want to take, that's all up to you. I just give an example. Yesterday evening only, late evening, we were seeing the patients of CKD, and patient was not ready to take insulin injection. Patient was uncontrolled sugar. I just explained the patient. I told the patient had come from Balotra. He was trying different type of oral anti-diabetic agent. Patient sugar was not controlled. Even patient was 1.9 creatinine. With all the patient medication was not as per his eGFR status. I explained the patient that you have to start on insulin. There is no other treatment. And you have already the problem. Now nothing more can be done. Doctor साहब आपका इतना नाम सुन के हम बालोत्रा से यहाँ आए, इंसुलिन थोड़ी लेना. No. आप नाम सुन के आए, इसका मतलब मेरे को गलत ट्रीटमेंट लिखना है. I am not supposed to write something which is not evidence based, something which is not to be done for you. I have to write the best treatment for you. हमने दवाई लिखी. If you don't want to take, it is all up to you. आप मेरे प्रेस्क्रिप्शन पर गलत क्यों लिखवाना चाहते हैं? Why you want me to write something which is not authentic, which is not scientific? So I have written the treatment. If you don't want to take, it is all up to you. I have written my file. I have written why I am writing it. I have done your investigation also. We have repeated. As per this evidence, you should be on so and so insulin. Now you go buy the insulin. If you don't want to take, then we can't help you for that. And then patient immediately accepted it and he started the insulin therapy. So this is what normally happens. If you are confident, I'm sure every day, like we are, I should not say that how many patients, but like whatever the 10 patients, if I'm telling them to start the insulin, we will not have one single failure in a day. I had not seen even last 3 months, in last 100 days, if you ask me, you have told 100 patients to start the insulin therapy or 1,000 patients to start the insulin therapy, none of the patients had disagreed that patient will say that I will not start the therapy. I'm sure here the Malay is there,
Yes.
Meet is there, Tarjani is there, even now Dhruvi is going to talk, and they all have worked with me and they all will agree that, once I tell the patient that patient has to be on insulin, even sometimes my associate doctor, sometimes Meet, Malay or Dhruvi will say, sir, आप इतने गुस्सा होके क्यों बोल रहे हो? अभी नहीं लेना है तो चलेगा 3 महीने बाद. But no, once we have decided, then yes, it has decided. Either you are not confident, it means there is no alternate therapy. When you will be writing, how can you give a patient को 2 रास्ता? मैं हमेशा patient को कहता हूँ कि आपके पास जब एक ही रास्ता है, तो you can't choose it. If you have, आप 2 रास्ते पर खड़े हो या 3 रास्ते पर खड़े हो, then you can think of that. Yes, I can divert here or there or that way. Right. Here only it's a one way. You have to go with that. Sorry, Dhruvi, we have taken more time, but
before Dhruvi sorry for the technical glitch that we were having. We are up and about now.
Dhruvi, can I take 1 minute from your time? Just wanted to add something to what you said. Yeah, so sir, it's actually, from your point of view or from my point of view, basically patients who come to us, they come to us, with the knowledge that we are specialists. And then once you tell that lagana hi padega insulin, so then they know ki kuch bacha nahi option. But if they go to a general physician, so they will do doctor shopping. They go to 3-4 doctors, and उनके दिमाग में एक doubt ये होता है कि मुझे इसकी आदत पड़ जाएगी. So I was just going to say, now recently I learned it, how to address that question. So I tell them that insulin is not habit-forming drug. We give it to patients who are pregnant, and once the baby is delivered, then we stop insulin. We give insulin to patients who go for surgery and we stop it. It doesn't make them habitual with insulin. But in your case, if your body is, not having any insulin reserve, you will require it probably lifelong. But it is not that insulin is making you habitual. It's that your body doesn't have insulin. That's why we are giving it. So that is what I just add, and I think it works. When you
I agree with you,
doubt,
Rakesh. I fully agree that primary care physicians or somebody who is practicing or just started his practice, he may not convince the patient because patient is otherwise going for shopping. But I tell you, before 20 years, you and me were also the junior doctor. And
right.
At that point of time, when we were started writing ourselves as a diabetologist, the patients were not ready to take the insulin. So I remember before 20 years, but before 20 years also I was the same. I mean, in my practice in 2000 also, when I was practicing as a diabetologist, if I tell that patient that, yes, you have to be on insulin, just before some days I was talking with Dr. Meet, and he also goes to Kalol, which is a Ahmedabad district only, I believe, but it's a small town. And where he's practicing, and he was telling me that Bansi that, patients are not ready to accept the insulin therapy many times. And so it is, how confident I told him that suppose you are telling your patient now go to Ahmedabad and you have to get your angioplasty. Go to Ahmedabad and get admitted in ICU. Or he is also running a hospital. I mean, in that hospital, there are a lot of admission what he is doing. I tell, if you tell your patient that get admitted, they all get admitted. I mean, they all believe him and they all do whatever he is saying, they do it. It means how confidently you are saying that is more important, whether you are a junior or senior. The problem is we are not confident. I am sure any junior physician in India, if he knows that what is type 1 diabetes, a 5-year kid also, he will not write tablet. He will not write insulin. He will not do such thing. Right. So it means it is the confidence which is convincing the patient.
True.
And confidence on your face, in your mind, that conviction will definitely convince the patient. It is, I think, the conviction which is poor, and that is what we had decided that iSchool will definitely help and improve the conviction of the doctors, and it will improve the convincing power of doctors also.
Right, sir.
Once again, thank you. Sir. Now over to Dhruvi.
Thank you.
Thank you, Rakesh.
Thank you, sir.
Thank you, sir. It was indeed a very, very charging discussion. We come back to insulin pump, and like all technologies have a little drawback. We had a little glitch with technology, and I'm going to be talking about insulin pump from the basics till the latest closed loop pump, which we recently have had in the Indian market. So we are celebrating 100 years of the discovery of insulin, and we've come a long way from 1922, from the animal insulin preparation to the current era of analogs, insulin analogs. In the 1960s, there was this Mr. Arnold who prepared the very, very first huge insulin pump, which you could put it on a backpack, move along with a reservoir of insulin. And, it went into the subcutaneous tissue. Currently, we are in an era where we have options of various different insulin delivery systems, be it a syringe, be it a pen, to the very closed loop pump that we are going to be talking about today. So there were the traditional insulin pumps which had their, cannula, and they were an insertion device where you had to manually insert and disconnect manually. It had a lengthy tubing system, and this is the picture of the very, very, primary mini-med paradigm and the Accucheck Roche pumps that were there when I started actually learning about diabetes and pumps. And they are still existing. You can still, see it in the market. A lot of patients are still using the Medtronic Minimed paradigm insulin pump. It had variable basal delivery. It had a prolonged bolus delivery also as one of the options. It had a temporary basal adjustment as one of the very nice features, a bolus calculating feature. It also had a memory to record. It had a downloadable care link, link which you could connect it to the computer and download the whole data that the person with diabetes puts into the pump. And, you can even put a blood glucose reading and it'll give you a carb count like a bolus wizard. Warning, it used to give warning for any low battery, low insulin, and even occlusion of the pipe, tube, or the cannula. It had a safety mechanism to prevent any accidental delivery of extra dosing of insulin. And of course, it came with a 24-hour support, a full training, and a 30-day guarantee. Now, why do we talk about the pump therapy? Why is it a tad bit superior when we are talking about any kind of insulin therapy? There is multiple daily insulin injections, and then there is this continuous system of insulin infusion. So when we talk about the CSII, or the continuous system of insulin infusion, pump therapy, be it the iSchool pump that you're using is also pump therapy, to the latest picture that you're seeing on your screens right now is also a pump therapy. What does it do? It gradually and slowly gives insulin drop by drop into the system, either subcutaneously or IV when we talk about the hospitalized pump therapy. And it is a very well regulated insulin dosage system. It gives us very, very less glucose variability. It improvises on the A1C numbers, reduces in the duration and the frequency of any kind of severe hypoglycemic episode. In fact, there are studies which say that there is a 50% drop in severe hypoglycemia versus people who are not on the pump therapy. Of course, it is improving the quality of life, because here you are changing the cannula once in 3 days versus taking insulin, 12 times, in more than 12 times in these 3 days time period. And there is a very, very precise delivery system. We do have pens that deliver 0.5 units of insulin, but the pump can deliver 0.05, 0.025, and 0.01 units. And this is specifically very, very useful for infants, for toddlers, and for somebody with brittle diabetes. Now, what are the benefits when we are talking about the insulin pump therapy? We are going to, compare it with a multiple daily injection MDI regimen. An MDI regimen is, of course, given to a type 1 or a pregnant lady who requires insulin 4 to 5 times a day. It has a fixed unit, and you have to mentally do the math, versus when in the pump therapy, the cannula needs changing only once in 2 to 3 days. The precision of the units are up to 3 decibel places, and the readings can be altered. There is a different amount of basal system. You can give different basal dose at every half an hour, every hour, or even every minute. The basal dosages can be changed. There is a bolus wizard, of course, and various different bolus pattern can be used when we talk about the insulin pump therapy. Now, when we recommend a pump to a patient, to the parents of a type 1 diabetic, they automatically feel that, it is a therapy which is like a magical cure. No, this is only a tool. This is kind of a luxury. That is what we teach them, that the ultimate target is to control the blood sugar levels. Whether you do it with a syringe, whether you do it with a pen, whether you do it with a pump, all of these are just a kind of a tool for better management of your glycemic status and for a better achievement of A1C and for pushing away your complications. You still have to check your blood glucose in spite of being on an insulin pump. Only if you are, on a self-calibrated sensor, which is along with the sensor augmented pump, you are not required to check your BG. Again, still you are going to do it, because not everything is trustworthy. Not every technology is, foolproof. You have more freedom. You can't, you don't have to graze around and, depend on your pens and syringes when you have to take an extra meal or you want to snack. Blood sugars might not always be in the target range, and having a pump does not mean that automatically Sara blood sugars control mein aa gaya. It has to be connected to a device to download all the data for, involvement of a healthcare professional to help you set the dosages. Now, these are the insulin pumps that are available today. This is what we are going to talk about. On your left side is the older Medtronic Minimed pumps. There is a sensor augmented pump, which is the 670G, and now we have the 780G, which is the artificial pancreas. And then there is a sensor augmented thing, which using a DIY looping system, you can use the Dexcom G6, or you can use the Guardian Medtronic.
The slide is not visible.
Pump through an artificial software that can be there on your phone and create an environment of
Dhruvi,
system or an artificial pancreas.
Yeah.
Now, what are the components of insulin pump? Very easy to understand, but the picture is going to tell you that there is an infusion set. I'm starting from the right. There is an infusion set along with the tubing system. There is an infusion set insertion device. Then, of course, the pump, a reservoir which is going to hold the insulin, and of course, an insulin vial. You either can use a regular insulin or a rapid acting analog, depending on your choice. This picture is actually showing you a sensor augmented insulin pump. There are pumps which are not sensor augmented, and you can use them standalone as well. But the beauty of a sensor augmented pump is they work in a semi closed loop format, and this is where they can automatically shut off and prevent any kind of hypoglycemic episode. We talked since the afternoon about the basal bolus insulin delivery system. We talked about the pharmacology of insulin in a natural or a normal non-diabetic human being. And this is how the normal insulin system works in our body, that there is at every 3 seconds or at every couple of seconds, there is production of insulin, which forms the basal system. And at every ingestion of food or at every meal for breakfast, lunch, dinner, or snacking, there is a bolus extra production of insulin to cater to the carbohydrate that we are eating. And the pump is going to mimic this kind of insulin physiology of a healthy pancreas, thereby, trying to produce the same kind of environment or almost similar kind of environment that God has given us. So this was a very beautiful picture that I found from the internet, which is comparing the MDI along with the blood glucose levels when you're taking the insulin. At every rapid acting shot, the sugars, goes down and then come back up when, there is lack of insulin again in the body. And so the waves come and go. There is an ebb and tide kind of a situation in the body. In comparison to when you are on an insulin pump, if you can appreciate that there is a constant inflow of insulin. For an MDI system, despite of a basal insulin, you know that a 24-hour acting glargine is also not 24-hour acting. The action weakens or stops at around, say, 20 hours or something. And for those 4 hours where we know that the insulin action is almost going to be negligible, we as HCPs give a bolus shot. Now, in comparison to what a pump is going to do is continuously give insulin or infuse insulin through the subcutaneous tissue and produce almost a flatter graph, almost a flatter glycemic variability chart, thereby preventing any peaks and troughs, any ebb and tides. And this is what is going to help in preventing the complications further. There is a very beautiful picture. I've not put it into my slides over here. But when we talk about a continuous glucose monitoring system, there is a picture which says that at 7 HbA1c also there is a different amount of glycemic variability waves which can be present in different kinds of people. And it is this glycemic variability that is targeted by the insulin pump therapy through smaller doses of the basal insulin infusion rate and the bolus of the same insulin. Now, a lot of people question us that, when in MDI, there is a basal bolus therapy, but for the pump, you use the one same insulin that, goes into the reservoir. So that same insulin, the same regular acting or the same rapid acting analog, when it goes into smaller regular infusion dosages, it forms the basal rate, which can be separated, individualized depending on the person's physical activity, food, nighttime. You can take care of the Dawn's phenomena that occurs. You can take care of your swimming, athletics. You can take care of n number of activities that you can go through, and even the inactivities that the person is going through. So that brings us to the point that who is an actual candidate for a pump. And we know that, again, when we talk about insulin pumps, we generally talk about them being designed for type 1 diabetics. And again, it's not so true. It is quite gaining popularity with type 2 diabetics who have uncontrolled diabetes, for people who have brittle diabetes, who have females with hyperglycemia in pregnancy, people with a very, very erratic schedule, people who have a varied work shift, frequently are traveling, have a desire for flexibility, are tired of multiple shots of insulin. Our athletes have to temporarily adjust their basal dosages, have to disconnect themselves and need some waterproof options. Now, the success of this insulin pump therapy depends on selecting of an ideal candidate. It cannot be just any random person. We need to extensively educate this person, and not just the person with diabetes, but the family, the friends. There has to be a constant motivation, and you have to implement a very, very sophisticated program of educating, counseling, as well as follow-up. So now we come to the next section of our presentation today, that how does an insulin pump work? Now, this is a pump with a tubing that goes into the subcutaneous tissue of your skin, and the insulin infusion set is going to drop by drop continuously infuse insulin into the skin, into the subcutaneous tissue. Now, there are various different cannulas that are existing. Just for your general knowledge, there is a Surety kind of an insulin infusion set, which is inserted at 90 degrees and the needle stays in. There is a Silaut infusion set, which is inserted at 45 degrees. And then there is a very, very popular quick set, which is inserted at 90 degrees. And this is the one which we mostly use in our practice. The reservoir or the cartridge holds almost insulin up to 300 units. The insulin is typically stored in a glass vial. You cannot store it in the cartridge other than when you're using it, because ideally, these cartridges need some sort of stability. They are of the disposable plastic kind, which will only come from storing the insulin in a glass vial. The beauty of the insulin pump comes in the basal rate patterns. The pattern for delivering the basal insulin throughout the day can be customized to suit the individual, and you can reduce the basal rate at night, not like Glargine or not like the Degludec, wherein you give the insulin subcutaneously once in a larger shot, and there are the hexamers get diffused according to their own format. You can change the basal rate patterns early in the morning, pre-dawn time, and you can change it according to your scheduled exercise timing or your gym timing for the kids, for the elementary school timing, and you can keep it different for when you're playing or when you have a dancing schedule, and so on and so forth. There is something known as a temporary basal rate, and this temporary basal rate is actually very useful for type 1 diabetics going through their honeymoon period, or teenagers going through their growth spurt during puberty, are going through weight gain or weight loss, people who are on corticosteroids, especially during these times of COVID when people are put on steroids. They have a different routine from eating, sleeping, or their exercise routine changes. You can change it according to the seasons. And, for females who have a different dosing during the menstrual cycle. Basal rates also need to be changed for while you're driving, while you're ill or under stress, like when you are presenting something, when there are blood ketones, or when you're fasting. That brings me to another question of how to bolus when you are eating. So there are various different kinds of bolus patterns, also options available on the pump. There is one that is a standard bolus. You press the button, the insulin goes, it is absorbed, and it works for your food. The second point is like an extended bolus. An extended bolus is one that you fix a time period for the absorption of the bolus insulin to go into the system. And it is called a square bolus. That is a gradual absorption of insulin. And it is generally given for food, oily food that you're taking, like parathas or, some kind of cheesy foods. Then there is a combination bolus of the standard and the extended bolus. So it is like a square bolus plus the spike bolus, wherein there is a small portion of the bolus dosing which acts immediately. And then there is another square wave which goes very, very, slowly, like for a pizza or like for an ice cream, wherein you would need the spike and along with a square wave as well. Then there is a super bolus, wherein you have the standard, extended, as well as the combination all together, and you are even using a part of the basal insulin. So all of this can be used together for the time when you are in a wedding or something, when you don't know what you're going to eat, how you're going to eat. And this is the time when you use the super bolus, be it your wedding or somebody else's wedding, or in an opposite situation where you are in a function where you have to dance, or you have to do a lot of work. So this is all only in the brief. It is not as easy as it looks, and you have to have a pre-pump session for the parents, for the kid, for the peers, and even for adults who are involved with a child, and adults and who are involved with their spouses. So you have to establish goals for them. You have to teach them carb counting. You have to teach them the insulin carb ratio and talk about correction factors. And you have to teach them and empower them to manage their own hypo and hyperglycemic episodes. A self-adjustment of the insulin, be it in relation to the carbs, correction dose, physical activity, or even alcohol intake, has to be taught to the person who is actually going to be using the pump therapy. They need to understand how to fill in their cartridge, how to fill in the reservoir, how to, prime their infusion set, check the sites, how to manage at the day of travel for exercises, how to troubleshoot and solve any kind of pump issues, understand their own blood glucose data, and accordingly down titrate or up titrate the basal and bolus dosages. And they should at least have some basic information onto their basal bolus therapy. So in case of the pump failing, not being able to deliver insulin, they should know how to switch back to their injections. Now, why are we talking about this pump therapy? Because apparently we are in an era where A1C is not enough, and we talk about a newer parameter called time in range, which is recommended for all other people with diabetes, be it type 1 or type 2. And this is another very interesting parameter, which is telling us that the more amount of time a person is in the time in range period, the lesser are the chances of the complication. So now, what is the time in range for any sort of diabetes? It's generally between 70 to 180. You can individualize that depending on the age of the person. Be it for geriatric, you can slightly reduce your target for hypoglycemia and put it, say, between 80 to 180. And for kids and for toddlers, again, you can keep it from, say, 90 to 180. Individualize it upon the discretion of the physician who is actually treating the person. So that brings me to a very, very newer, latest insulin pump system, the 670 and the 780G pump that is available, and which we are now calling it as the closed loop pump system or the artificial pancreas. Now, additionally, other than the insulin delivery parts that we just studied, it also has a continuous glucose monitoring in a form of a sensor. It has a software that can be linked to that can be downloaded on a computer or on your phone, and you can actually monitor and take care and adjust the dosages accordingly. And this works in a micro bolusing format, a tad bit different from the basal bolus therapy of the insulin pump that we just talked about. So this is how the 780G system works. There is a pump. It is, again, linked to a Guardian Link 3 transmitter. There is a Minimed mobile smartphone application. Again, you have the same kind of software into the computer. You have an AccuCheck Guide Link meter where you can check your blood glucose, and the pump can also detect your sugars using the Guardian Link transmitter. There is a server, of course, and a whole CareLink Connect application that is going to link everything together. The pump can sense when to give you an extra, say, insulin in the format of 0.01 unit, and to keep your sugars within the preset limit. So now I'll give you an example. Say, for example, I'm setting my sugars between, say, 80 to 140. And the moment my sugars drop to 79, the Guardian Link transmitter will tell my pump to shut down temporarily. And 79 is not hypoglycemia for me, but I'm still scared that if it drops below 70, I don't want to set that limit. So I've set it at 80. And the body also has its own mechanism of increasing your sugars back to the normal range. So the moment you are at 80, 81, 82, and your pump will restart again in a micro bolusing format. Inversely, if your sugars go to say 141 and your insulin sensitivity factor is telling your pump to give an extra dose of say 0.02, the pump will give your body the extra insulin of 0.02 units to bring your sugars back to below 140. That is how your body stays in time and range almost 99% of the time, the 1% being the human error that can happen anywhere. So this is the glimpse of what I just told you. The CGM sensor communicates with the CGM receiver. The receiver communicates with the insulin delivery system. Here it is the pump. There is a whole controlled algorithm device that communicates with the pump to tell how much of an insulin needs to be given in an extra dosage format and when to shut the pump down and again when to restart it. The only difference between the semi-closed loop pumps and the actual closed loop pumps is the difference of the semi-closed loop pumps cannot restart themselves. The closed loop pumps can restart themselves. So this is the latest technology that we are talking about, the complete closed loop system of the 670G hybrid and the 780G hybrid. And we are in a time and era where we should at least give this option to our patients, that there is something like this existing for you to at least try. There are people who are using the older pumps, the semi-closed loop pumps, and of course the Paradigm Mini-Med also through a do-it-yourself looping method. They use the Medtronic pumps, they use the Tandem, they use Omnipod, Animas, everything. And there is a actual hacking system and openaps.org where you can make your own application. The kind of application where we were talking about, the algorithm can be made, and this communicates through a sensor to the pump as to how much insulin needs to be given. Most of the pumps which are latest are waterproof. The older ones were semi-watertight and non-watertight. Now, how to shift a person from MDI to a pump? Now, there are two methods that we generally follow in our daily practice. Calculate your pre-pump total daily dose, reduce it by 25% or multiply it by 0.75 and divide that dose into a basal rate and into a bolus rate. And the basal rate can be divided by 24, and then you can adjust it according to the sleeping patterns and the daily activities or the diurnal variations. For the bolus portion, go for the carb ratio, understand what kind of a meal pattern the person is having and divide it into a very, very small dosaging for the tea, for the breakfast, for the lunch, for the tea in the afternoon again, and for the dinner. Correspondingly, there is another method wherein, where you do not know what could be a total daily dose of this person. And you take the weight, multiply it by 0.5, whatever number you get, again divided into two parts, a basal and a bolus. And that basal and bolus can be, again, the basal system needs to be divided according to the diurnal variations, and the bolus can be divided according to the meal patterns. It is very important for us to understand that the carb ratio of a person can be different. And for a patient with an A1C of 6.3, the first method that we were talking about is quite appropriate. But for a patient with an A1C of 9.2, the method 2 that we were talking about, weight into 0.5, is very, very appropriate. But for somebody with a good control, we can take an average of both the numbers that we are getting from the pre-pump total daily dose and from a weight into 0.5 number. You can get an average of these two numbers and then, divide it into a basal rate and a bolus insulin thing. Now, we always need a backup plan. What if the pump isn't working? So immediately the first thing should be a basal insulin injection, because the half-life of insulin that goes through the insulin pump is just a couple of minutes. And we should also have a mealtime rapid insulin injection that can, be supportive for the meals that we are taking. Always keep a log of the insulin carb ratios, the correction dosages, and the meal boluses, and keep a log of the off pump activity, because when you go back on the pump, you're going to require to calculate your doses again. Resume the pump when the basal insulin wears out. Of course, when you've taken a basal insulin injection, the half-life is still going to be 18 to 24 hours. So wait till the basal insulin, action wears out. Of course, there are some disadvantages. Like we talked about, technology always has some kind of a, drawback. Cost being the very first when we are talking about an Indian system. It is a steep learning curve. We learn a new thing every time a patient comes back to us. There could be a pump failure, difficulty with the cannula gets kinged, it gets, a lock somewhere on the door or something. Decay can precipitate if the pump has stopped and the patient is not aware of it. Skin infections are some very, very common things with the patch. These are the latest papers which I wanted to share. The first paper is about a closed loop delivery system and how it has been very, very helpful for the type 1 diabetic in improving the glycemic outcomes. The second paper is the use of the closed loop insulin delivery system in older adults. Again, I've kept these two starkly different papers because we should not be of the idea that a pump is only for a young teenager or a toddler or an infant. It is also for adults and geriatric people who are quite tech savvy and motivated enough to learn about the pump. So with that, I'm going to say that pumps add value to the life of our patient. Please put it up as at least one option when you're talking to them about the insulin pump delivery. Thank you, sir. Thank you.
Thank you, Dr. Dhruvi, for interesting session. I think all of us get benefited a lot, and especially those who are quite new for the insulin pumps. They must have got a lot of information from this session.
I hope so. We are still learning new and new
Yes,
things
definitely.
when it comes to the closed loop thing, and we are yet to study it further.
So Dhruvi, just one thing to add here, we have already the barriers for like insulin therapy. So I'm sure there are multiple barriers for pump therapy also. The cost is one aspect. I agree with that. So let us put that cost barrier that 80% of your patients or my patient will have a barrier of cost. So let us put that cost is not a barrier. But still there are a lot of patients who have a barriers of pump therapy, and cost is not a major challenge for them. They can afford anything. So how to convince them? I mean, what do you feel? Is it the patient or a doctor who is responsible for less number of insulin pump therapy in our country?
Thank you, sir, for the question. I'll say that it's the doctors first. It seems such a cumbersome method. When I was making the presentation also, I felt कि बाबा इतना कुछ सीखना पड़े other than the already existing things. And you have to spend so much of time with the patient to convince them that this is something which is better for them. Why would you sit and spend 1 hour of your practice where you could see 5 other patients and earn so much in comparison to spending that same amount of time for one patient who you are not sure, when you are not guaranteed that might take the pump or not? Or pump lene ke baad bhi, I myself have that point कि अपने को क्या फायदा? It's just that the patient will have a good glycemic control. A lot of peers that we talk to, they have the same ideology like I have. मैम उसको देने के बाद भी क्या रात को 12 बजे they will call us कि अभी मैंने दूध पिया तो मैं एक्स्ट्रा इंसुलिन लूं या नहीं इसमें से. And it is a lot of work, and unless and all you have a whole team who understands कि भाई pump को कैसे operate करना है, I feel it is a huge responsibility also. And in this day and time and era where we know everything is medical legally required to be answered, people will, or doctors will, refrain from initiating a therapy like this, wherein they have to stay more than 100% involved along with the patient in their care. And on a positive front, if you want me to say something, it is once the patient tries the pump and are savvy with the technology, it's a beautiful thing. And as doctors, we ourselves should at least try the pump, a saline pump ourselves, and understand, like, you had us all try the AGP, you had us all try the Dexcom, you had us all try the pump when it actually came, the actual 670G pump when it came, and it did put us a perspective in our minds how this actual thing is going to be applicable in my day-to-day activity. So the first barrier is the doctors, and मेरा जो सवाल था, nobody has actually been able to answer that. That what will the doctor get access for the patient satisfaction, and even the 1 hour, more than 1 hour, I'll say, that is spent along with the family. The family feels that there is some hidden interest of the doctor in initiating the pump therapy that we are so empathetically talking about. कि भाई ये मैडम कितना पंप के बारे में बात कर रहे हैं, 6 लाख का पंप दे रहे हैं, उसके बाद that's the thing which refrains the doctors from emphasizing on any particular therapy for that matter. That's what I feel.
So very rightly said, and this is really a major challenge, that as doctors does not want to spend so much time. They don't want to understand more about the pump therapy. As you are rightly saying, that 10% of our patients who can afford, but they don't want to put them on pump also, because half a day, not 1 hour, it is half a day of your practice will be taken by that patient and the family and the caregiver to teach them about the pump. So our next plan is that, after iSchool, we are planning to start a pump school also, Rakesh. And that yesterday only I was talking to the Medtronic managing director. He was here only, and we were deciding that because 780Z official launching ceremony they are going to do on 5th of Feb. But we have put just one patient. We had given them that let us put that patient on 780Z, and we were also discussing that how we can make more cost effective for the patient, because this is something on a hybrid closed loop. The patient can afford continuous glucose monitoring, nothing like it. But the problem is, again, as you are rightly saying, that it's like your half a day will go with the patients and the family members, because nobody wants to do it. But one more, which we had given him, and now we may do a one collaboration with them, like the way we have done with the Vito, that all the doctors who are not monitoring for their patient, their patients are not monitoring so often, and we asked them to give a free glucose meter to them. So similarly, Dhruvi, yesterday when I was talking to the managing director, we just asked them, okay, what you do with the old pump? They don't do anything. So they are going to donate us, and maybe 500 old pump will be with us in Diacare and Diabetes Care India, and we are starting pump school. And all those who are interested in pump therapy, they have not used, we will give them gift and then they can put that pump either to their genuine candidate who can afford, or to the person who is type 1 or type 2 diabetes, she's becoming pregnant, or a GDM patient, or somewhere they want to go. So I think more they use, they will understand more the pump. And once you will know the pump better, then I'm sure you will be able to convince us also better. But this 780G is real game changer. I believe me, this is real game changer. If someone can afford, I think 780G is really going to change the life. It's really artificial closed loop. You just have to put it, and you see automatically it is going to increase the basal as well, at the same time it can give you also the bolus. With this, if there are some questions, I think there are some comments are there.
But sir, I had one question.
We don't want something that says 24 hours in. Yes, it's very true. There is one anonymous attendee who is saying that they don't want to keep it, and that's the reason we have patch pump, and probably we are going to have patch pump by Roche in 2022. So by August end, we will be having the patch pump also will be available, and some of the patients, they bring patch pump from outside the country because they don't want something to be attached with them continuously. So that's very important. Sometimes it is barrier for some clothes also, like it cannot be hidden everything. This is something which is one should not hide it also. If somebody is so much feeling that I want to hide, I don't want to show that I'm a type 1 diabetes, and for them it is not required. I think first thing we should convince them that you should not hide it. You should not feel shy that you are a type 1 diabetes. You should tell everyone that I am a type 1 diabetes. This Apurva Gumbar, I'm sure all of you know, she is a MD pathology and now she is working in field of pediatric diabetes. She is currently in USA. Her father is physician, Delhi based, senior physician. Apurva is a type 1 and the father was, so much so shy that he was not going to tell anyone that his daughter is type 1. Apurva met me before a few years. I told her that she was doing her postgraduate at that time, or I think MBBS final. I told her that you should tell everyone, including my father. And then I called Dr. Gumbar also. And we talked and I went to meet Dr. Gumbar also in his clinic. And then I met his wife, who is also a gynecologist. And the second day only, Apurva decided that she is going to tell everyone she is type 1. And on the next day, on her Facebook, she put that I am type 1 and I am on this. And then we convinced her on insulin pump therapy. And since last 5 years, she is doing very well. I mean, now she is the star for type 1. We had asked her to become the part of Life for this idea of young leaders program, and then SPAD. She attended all SPAD meeting, and now she married, and she is even giving the talk in most of the type 1 meetings also. We also invited her in RSSDA type 1 diabetes network program and all this thing. And now Dr. Gumbar also running a free type 1 diabetes clinic in South Delhi. So, if you are feeling that you can hide or you don't want to show someone that I'm a type 1 diabetes, then they can't do it.
Right.
The same case, I'm sure everybody knows the judge. Jay is a choreographer. She was never hiding that she is a type 1 diabetes. She was using the pump. But when we met her, I told that, when you are type 1, you should tell others also. And then she started, on social media, diabetes. She had started her foundation and she's doing very well. So for type 1 diabetes, I think it's a pump therapy for them if they can afford. Nothing like it, because it's a continuously insulin which is given. It's the most physiological way of replacement. Cost is a major challenge for our country, but this 780A is really game changer. I always tell that yes, you may have cost is a major challenge, but out of your 100 patients, one may afford. So if your one patient can afford, please give her. If you feel that you can't give it, but you have a right candidate, you have a right patient in front of you, please refer the patient at a right center who can guide them, who can give them insulin pump therapy. And this is also what I'm getting. I have more than 20 patients who are daughter or son of some doctor, and they are on pump therapy from all across the Gujarat. So if you are treating them, I'm sure you will come and they will get.
Ansi, can I ask one question?
If you start patient on pump therapy, you will find that they will bring you one more patients for pump therapy. So this is like that. With this, I think now we should end it. We have one more.
Bansi bhai, we had some questions. Bansi bhai.
Dr. Suryakant Pandit want to, there is some patient, insulin patient in a educated patient. Educated patient, yes, it should be given to all educated patient only, but somebody who can't afford, then it's really a challenge for it.
Bansi, can I ask one question?
Kerala government is the only government of state government which is giving insulin free pump also, insulin pump free to the patients. So from government side. Now ISRO, ONGC, they also provide needy patient insulin pump therapy.
Bansi bhai, I have one question and Dr. Pratap also has one question.
So Meet, it's time to end.
Yes, sir. Sir, but Dr. Pratap and Dr. Rakesh sir wants to ask some questions.
Bansi, one question only.
Yes, sir. Please.
Is there any difference in recurring charges when you are using a conventional pump as compared to this newly introduced?
4,000 rupees.
Same recurring charges.
4,000.
Okay, it remains same. Okay.
Okay, I have one question. Dhruvi, you covered the topic very well. And the question relates to DIY. So if you can explain, I hear often that there is some open source software DIY which brings down the cost. So can you throw some light on that, Bansi sir or Dhruvi, anyone?
So DIY stands for do it yourself.
Yeah.
जब हम ये क्लोज लूप सिस्टम की बात करते हैं तो उसमें ऑलरेडी देयर इज एन एल्गोरिदम एग्जिस्टिंग.
Right.
What people did was, जो भी पुराने वाले पंप्स थे वो सेंसर ऑगमेंटेड हो या नहीं हो, मेट्रॉनिक का मेट्रॉनिक के साथ ही यूज होता था पहले, रॉश का रॉश के साथ ही यूज होता था. बट देयर वर पीपल हु हैक्ड द सिस्टम एंड देयर इज एक्चुअली अ DIY .org open access system wherein you can make your own algorithm. You can connect that pump to any sensor. A real-time sensor, you can connect them both using that algorithm, and that makes the pump a closed loop system pump. And this was actually, I think, first done by a father whose kid was a type 1 diabetic. And then he produced the data at ADM. And uske baad the thing got caught up, and then everybody started to use it. And then there are actual scientific papers through the JDRF where there is a data where people are using the DIY looping system. They call it looping because they actually formed a circle of the open system, and they connected a pump and a different sensor system through their own made algorithm. Now every person needs their own algorithm. किसी का किसी पे नहीं चल सकता. For example, for Rakesh Parikh sir, there is a different kind of algorithm which you have to put in your daily activities, your food charting, and your insulin dosaging. उससे automatically you will get an algorithm that will help you to connect the sensor and make the pump communicate with the sensor. और likewise वो फिर वो micro bolusing से insulin देता जाएगा या फिर pump को बंद कर देगा.
Right. So basically, you can modify the older pumps.
We can modify the older pumps, but again, it also had its own drawbacks. कि भाई कभी बंद नहीं हुआ तो pump, या फिर there were a lot of people who were not able to program the algorithm that well because it's not an easy thing to do. Even for HCPs, it's not an easy thing to do. Plus, जो सेंसर को हैक करने वाला डिवाइस आता है, that device is also quite costly. So people in India have ordered it from the US, and there are, I think, only a couple of handful of people who are doing the DIY looping in India also. Jazz keeps on putting it on Twitter, but then it fails.
But the best, which what Jazz is doing with a pump, which is the pump and the Dexcom, which is the best. And I had tried with the 2 of my patients, and that one yesterday only we were discussing. His sugar was absolutely well controlled, and actually I asked Jays only to teach him, and now he is teaching by one more patient of mine. So we are also promoting the DIY. Why not? We should promote it rather. But the issue is that guy is using continuous glucose monitoring. On that is a separate that hardware which is doing the continuous glucose monitoring report, and he is using the older insulin pump and loop which he has purchased. Now what happened, unluckily, day before yesterday, his sugar was showing on that was some 800, and suddenly his pump started giving extra amount of insulin continuously. And he started getting symptoms of hypoglycemia after half an hour, 1 hour. And then he checked that his insulin was going like crazy. It's like 10 units per hour. It's like more than that. Suddenly it is increased. And then when he had said, seen the report, it was still showing some sugar report of 800 something. So there was some, the first thing what he had done is disconnected both the things. He checked his sugar again. It was at that point of time 60 only. So I will request DIY should not be attempted for young children. It should not be done somebody who is very young or 15, 16. If it is taken care by themselves, then it's fine. If it is taken care the child is by caregivers, then you don't do it.
Right.
So DIY is not an ideal solution for some young children. It should be only for adults. And it does not have any, it can have a legal problem also. So we should not promote as a doctor. If something goes wrong, child may die. So the doctor can create a problem, and it is not approved by any US FDA by this. But patients can do, and we can support them but it's their own responsibility, and they should be also adult one. That is what just to say about the pump. But I just want to tell you this, how newer technology is coming. Suddenly SCL had come and artificial pancreas had come, and now you can see in my clinic with the metaverse, the Rajiv COVID also. Can you see here? See,
Yes. Hi Rajiv, how are you?
He's sitting in Mumbai, and you can see in.
Just going to ask.
See, this is the technology. How fast it is changing. We were talking about insulin pump therapy, and now suddenly Dhruvi started talking about 780G, and then Rakesh started talking on DIV. Then I told, let me show you also one good technology. So just to tell Rajiv for a few words, and then we will end. Rajiv, it's all yours. Please sit. Pleasure. And we close it, right? So I've been listening to the iSchool thoughts.
Hello.
Good evening to everyone. Fantastic sessions all through, and I've been a silent listener to all the conversation which has happened, and looks very nice. Ahmedabad has been very welcoming to me since morning. Fantastic. Have a fantastic day, and I think tomorrow also rock all of you. Thank you all, and see you all in person very soon, all of you all. Bye-bye.
Bye, Rajiv. Bye, Rakesh. Bye.
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 Bye. Good night to all of you.